Good afternoon, ladies and gentlemen. I'm Dr. Wang Chen-Chi from Taichung Veterans General Hospital. Today it is my great honor and pleasure to share my experience on using laryngeal EMG for voice disorders. Many focus on unilateral vocal paralysis. And first of all, I would like to express my heartfelt gratitude to all the speakers and all the moderators and all the attendants for supporting us to achieve a successful Congress. Specifically, I thank Amanda Hu and Izia for working with me in this laryngeal EMG symposium. Hopefully, we can achieve a renaissance of laryngeal electromyography in the clinical practice. So I have nothing to disclose in this talk. I introduce myself briefly. My hospital is Taichung Veterans Hospital, located at the central part of Taiwan. We have 1634 beds. It's a tertiary referral medical center. I have performed the laryngeal EMG since year 2005. As you all know, unilateral vocal paralysis, or UVFP, can induce a glottal closure gap during phonation, and cause hoarseness or spiration during the swallowing. In the past, I also used many laryngoscope guide injection. For example, in this picture, I use a telescope mentioned by Dr. Wang and do the transoral injection, or use a flexible laryngoscope like Peter used and perform the transoral injection in this picture, or use flexible laryngoscope guidance, transcutaneous, transcervical injection. And I also performed the direct laryngoscope and the fat injection under general anesthesia for patients who cannot tolerate the IFS procedure. But I started to think, could we perform the laryngeal injection as easily as the cosmetic injection? So according to my experience, most of the patients with unilateral vocal paralysis ask me two questions. The first question is, will the paralyzed vocal fold recover? But in the past, we asked the patient to wait. And I don't think it is reasonable to answer the patient, you need to wait 6 or 12 months. Actually, we can answer the question by using the laryngeal EMG. The laryngeal EMG was introduced in 1944 by Whitehall and Patel. And but in the European Laryngology Society, laryngeal EMG proposed a guideline published in 2012. They mentioned it is the only test that can provide otolaryngology with neuromuscular status of UAP and the prognosis information. However, they also emphasize that many laryngologists does not routinely use laryngeal EMG, even though it has been considered as a valuable diagnostic tool for more than 70 years. Why? Have you thought about why? Because I think using laryngeal EMG only for prognosis prediction does not satisfy our patient. They are not coming for fortune telling. They are coming for treatment. And think about these two scenarios. If after the laryngeal EMG examination, you tell the patient you have good prognosis, and your patient asks you, when my vocal fold function recover, we still cannot answer that question because the synkinesis can happen, although the patient has regeneration of the nerve. And if you tell the patient you have poor prognosis, we only make them sad without any treatment. They still need treatment. So the treatment is the most essential part of the management of UVFP. And they always want a miracle to free them from symptoms soon. So the second question they ask me is there any simple treatment to improve my voice quickly? As you all know, and mentioned by the other doctor, the injection laryngoplasty is commonly used to patients with unilateral vocal paralysis and medialize. We can medialize the vocal fold to achieve a better glottal closure. Because the TA-LCA muscle complex is the target of both laryngeal EMG and injection laryngoplasty. So I start to use the injectable needle electrode during the laryngeal EMG procedure and inject the hyaluronic acid into the TALCM muscle complex. I published the first paper in year 2012. And so many years I have performed this procedure smoothly without a big problem. So I contribute the book chapter in the textbook of vocal fold injection published in 2021. This is the time-lapse photography I took in on January 13, 2023. During 2 hours, I have injected 12 patients by using this technique, 12 unilateral vocal fold paralysis patients, and also 3 patients with spasmodic dysphonia. As you can see, the procedure is very short, and the patient received this treatment one after another, and they lie down on the surgical table. I perform the laryngeal EMG. After finish the laryngeal EMG, connect the HA syringe and inject the HA into the paralyzed vocal fold muscle. So it is the patient usually comfortable, and I don't use any anesthesia. And also, the doctor in other countries also uses the technique. This is easier, published the paper in 2017. And also Amanda, who published her paper in 2020. And we also have the same technique and the similar feeding. This is a very convenient procedure. So I would like to share my standard operation procedure for you today. For performing the laryngeal EMG, I use the monopole needle electrode. This is the injectable needle electrode, and use a stick to surface electrode. One is ground electrode, the other is surface reference electrode. And I puncture the needle through the cricosine membrane, like this picture. And because the needle is very small, it's a 26 gauge injectable needle, so it's very thin. We don't need any anesthesia. I work with my neurologist, Dr. Zhang. I appreciate him to work with me in the first beginning. And I puncture the TA and LCM muscle and the CT muscle from the normal side to the paralyzed side, so we can compare the laryngeal EMG from the with the both sides. And I follow the rule of 2 for my laryngeal EMG procedure. And in each side, we puncture 2 muscles. The CT muscle represents the function of superior laryngeal nerve, and the TLCM muscle represents the function of recurrent laryngeal nerve. And in each muscle, we ask the patient to perform 2 tasks: to keep silent or to phonate with vowel E. And in each task, we detect 2 signals. For example, when the patient keeps silent, we can pay attention to if there is any fibrillation signal. Or when the patient phonate, we can see if there is any reduction in the recruit motor unit potential. This is the picture showing how I puncture the CT muscle. We can feel the inferior tubercle of the thyroid cartilage and aim at the CT muscle. And then I change the angle of the needle to puncture through the cricosine membrane and into the TLCA muscle complex. The signal will represent the function of the recurrent laryngeal nerve. And in the TLCA muscle, we can ask the patient to do 2 tasks. When the patient keeps silent, we can pay notice, is there any spontaneous activity? Usually, commonly is a fibrillation signal. And we ask the patient to phonate to see, is there any reduction of the interference pattern? What is a fibrillation signal? Fibrillation signal is a spontaneous activity happened in the resting muscle. If the muscle is denervated, not under neural control, it does not appear until 10 to 14 days after the nerve injury. So we should perform laryngeal EMG at least 2 weeks after the symptoms onset. And in addition to the visual feedback on the screen, we can see many spikes on the monitor. And then we also can pay attention to the very typical audio feedback. The sound of the fibrillation signal sounds like the raindrop on the tin roof. So I will show you this video. This spike are the fibrillation signal. And it's very typical. It's easy to remember and recognize. So the second task, I asked the patient to phonate with vowel E. Normally, in the normal side, we can see a full interference pattern like this. But if there is some denervation, the interference pattern or recruitment will be reduced. And for example, this is a full recruitment of the motor unit potential in normal muscle. But in the paralyzed side, if we find this kind of interference pattern, we estimate about 30% reduction in recruitment. And in this pattern, we estimate that the patient have a 50% reduction in the recruitment. If the patient have nearly no motor unit potential when they phonate, about 90% reduction. So I am going to show you the recruitment pattern. This is a full recruitment in the this is a normal vocal fold. In another patient, we estimate the patient has a 50% reduction because the number of the motor unit potential reduced. And in some patients, we can even cannot hardly define any motor unit potential. So this is a total or nearly total loss of the recruitment when the patient phonate. So we can follow the prediction rule proposed by Dr. Moonin and Dr. Rosen when I studied with them in UPMC. If the patient have normal or nearly normal motor unit recruitment pattern, and without the spontaneous activity, we define it as a negative test, and the patient will have a good prognosis. What is normal or nearly normal? If the disease side has 80 to 100% of normal motor recruitment, we define it as normal or nearly normal. Otherwise, the patient will have a positive test. The prognosis will be poor. For example, if the patient does not have a fibrillation signal, when keep silent and have this kind of a normal recruitment compared to the normal side, the prognosis is good. And if the patient has a fibrillation signal when keeping silence, or the patient has this kind of reduced motor unit potential when they phonate, the prognosis is poor. So I used this laryngeal EMG guide injection and collect a lot of laryngeal EMG data, and so I can publish the first prospective study paper of level 1 evidence to prove the prognosis value of laryngeal EMG with long-term follow-up with mean of 18 months. And as you can see in this paper, it is very easy to dichotomize to poor prognosis score or good prognosis score. It's easily because the recruitment reduction is significant compared to the patient with good prognosis. And if the patient received the laryngeal EMG at least 2 months after the symptoms onset, the laryngeal EMG prediction accuracy is as high as 90% with positive predictive value of 97%. So in this poor prognosis patient, if the injection laryngoplasty cannot satisfy, we can encourage them to perform the open framework thyroplasty type 1 as soon as possible. So this is the picture showing eye puncture and connecting a 1 millimeter HA syringe to the injectable needle electrode. And the needle is very thin. And now we have published the standard procedure in the JAMA Network. The video show example of right vocal fold paralysis with medium glottal gap. This is the voice before the injection. The voice is weak and breathy. We puncture the normal side. This is a normal side. And then we puncture the disease side through the cricosine membrane. This is a typical fibrillation signal that helps us to localize the paralyzed muscles. And when the patient for EE, almost no motor unit recruitment. And we inject the HA. His voice become better. And this is the stroboscope we record after the injection.
2, 3, 4, 5, 6, 7, 8, 9, 10.
This is a demonstration, and we also analyze our long-term effect. As you can see in this paper, we collect 74 patients, and about 60% of our patients can obtain a long-term outcome satisfactory after mean follow-up of 16 months. And another 22% of our patients received 2 injections in 13 patients, or triple injection in 3 patients. They also were satisfied with the long-term outcome. And in our practice from 2013 to 2022, by using this easy injection and early rehabilitation, 80% of our patients doesn't ask for any further open surgery. So we can significantly reduce the burden of our health care. And my conclusion is the Laryngeal EMG guided HA vocal fold injection is a good option of awake vocal fold rehabilitation for initial management of EVIP. We can follow up the rule of 2. Yeah, and the short-term effect is satisfactory. Long-term effect is possible. We can provide the Laryngeal EMG prognostic information for further management if needed in the future. So I think this procedure facilitates evaluation, treatment, and also collecting a lot of data for research. And we can better understand the physiology of UVIP. So just mentioned by Peter, different people use different technique to achieve the same goal. And like the ice cream, I hope my technique is a new flavor in the ice cream shop, and all of you can like this flavor. Thank you.
Thank you very much, Dr. Wang. Is there any question from the floor? All right, if not, may I ask you a question? Peter, please.
Professor Wang, thank you for your amazing presentation and the video showing how busy you and how many patients are going to see you in the same section. But just wonder, you can do all the 3 goals at the same time. You also interpret the laryngeal EMG finding for all these patients before you do the injection?
Yeah, routinely. Yeah, we puncture and collect the laryngeal EMG signal. And no matter the patient has good prognosis or poor prognosis, as I have mentioned, they are not coming for fortune telling. They are coming for treatment. So early rehabilitation is so important. I always inject 1 milliliter to improve the glottal closure, and they are happy about the result. Yeah, no matter how long you can experience the improvement.
And probably they are not concerned about the fortune telling part. Probably they just want to have their voice immediately correct.
Yeah,
shortly.
yeah.
So.
Because in my first practice, I do not do the treatment, and the patient asks me, "So what can you do for me after laryngeal EMG?" I say I can do injection laryngoplasty in the office or under general anesthesia with autologous fat. And the patient asks me, why don't you do that at one procedure? You have punctured me, why don't you do that in one procedure? So the first patient I met is a patient who received the C-spine surgery and had the vocal fold paralysis. He's very angry. He was very angry. He was a very successful businessman. He come to me and I say, oh, I can do this, I can do that for you. And then he asked me, is there any simple procedure? I need to get back my voice immediately. I need to go to mainland China to do my business. I say, okay, probably I can use this injectable needle to do some HA injection. He said, okay. But I say, you need to pay by yourself. He said, no problem, I have money. So I do the first injection for him, and it's very successful. Immediately he can speak and never come back. I call him by telephone. He said, oh, it's very good. So far, many years. And about 7 years later, he come back. I check his larynx. The vocal fold is still immobile, but the glottal closure is still good because of the early rehabilitation.
Dr. Wang, may I ask, as I know the hyaluronic acid effect only lasts for a few months, it's like temporary. Then I noted from your study that around like 60 patients only need one time of injection of hyaluronic acid to achieve long-term outcome, like with the mean follow-up time of around more than a year. So can you explain why it can reach long-term outcome?
Yeah, the first is the compensation. Yeah, so early rehabilitation can facilitate the compensation. During the absorption of the HA, the healthy side can compensate more easily without any treatment. So the first rationale is compensation. The second rationale is some patients have reinnervation, but because of synkinesis, the vocal motion cannot recover. But because of the reinnervation, the atrophic muscle becomes some muscle back, so replace the absorbed HA. That is the second reason. The third reason is according to the animal study, the HA we inject can induce the body to form autologous connective tissue, including the collagen and the hyaluronic acid. So the endogenous HA and the collagen can replace the absorbed HA. That's three major rationale for a long-term effect. Thank you.